The second speaker is Dirk Sommer, who is one of my colleagues at the World Bank, leads our public-private partnership work in the IFC, the International Finance Corporation, part of the bank. And what his group does basically is work with governments in looking at ways to work more closely together with the private sector in such a way that public money is leveraged into private resources and that the two sectors can work closely together rather than working separately, as one often sees in silos of public and silos of private that don't communicate very well. Dirk did his training in Berlin, and we're delighted to have him with us in the World Bank Group as one of the people who's leading our PPP work in health. Dirk.
Thank you very much. Thanks very much for having me today. After The Economist, I think we're out of time. We still haven't found the money. So I had prepared something a little bit fancy, flashy. I'm not sure it's going to work. I'm going to skip on it because in the interest of time, we really should probably move on to discussion rather quickly. So the topic that I wanted to talk about is public-private partnerships. And before I get in there and use up my scarce time, I want to use the benefit of being a late speaker and being able to tie in some of the stuff that other people have said and to bring it a little bit together. So I think the key point I think I want to take away from your presentation is really, yes, we can all hope there's going to be much more money. But the truth is, how can we do more with what we got? And public-private partnerships, in the eye of many of our client governments, offer that opportunity. Okay, so there is a sense that if you bring in the private sector under a contracting solution that defines very precisely what the private sector is going to do on behalf of the government, you can tender this, you can open up this tender process to innovative ideas that the private parties can bring into the table to deliver what we want to deliver much more efficiently than we can. Then I think out of what we have in terms of funding, we can make much more. Not sure we get to the ambition that we want to have a beautiful health system in either countries, but we're going to get more than out of it than we get today. So one example, I'm not quite sure, I'll find it here on the slide for now, but one example that's very timely for this, we're going to open this, or not we, but a company out of South Africa called Netcare will open this month a new referral hospital in the country of Lesotho. Lesotho, as you may know, is one of the IDA countries in sub-Saharan Africa, and had the privilege or the curse, essentially, of having a 400-something bed tertiary care hospital in its capital, Maseru, until a very few years back, that had swallowed up significant government funds and continued to swallow up significant government funds and absorbed a large amount of the donor aid that the country was receiving. So essentially at some point the Minister of Finance said, okay, if I do the numbers right, and it's always difficult to do in a government context, we're actually spending $10–15 million a year on that one hospital. And essentially, if you look at what the hospital does for healthcare, and I think some speaker this morning mentioned the discrepancy between talking about healthcare infrastructure and actually health outcomes. So that hospital actually contributed to the spread of disease. So people that went in there came out on average sicker than they went in. Okay? And the people that went with very serious conditions, they received essentially no meaningful service. And so this situation is sort of an ideal proposition for a public-private partnership because the government at that time was so fed up with its own many attempts to reform public provision. It knew the numbers. It knew basically we don't get anything out of this in terms of healthcare provision, but we spend a lot of money. And so they went to the market. We were lucky enough to be partner with them at the time and said, can someone actually please come into Lesotho, build a nice hospital, run it so that people get extra service and sort of stay within the overall resource envelope that we have? And the answer was yes. So it took us 2 years to do some analysis and due diligence and figure out the risk allocation. I think Thomas spoke very well this morning about the risks, why banks don't want to get into financing of healthcare. So it's ultimately about the risks. It's about commitment of government and players to provide resources to such a project. So it took us a while to package it, but the project was awarded last year. Earlier this year, they opened a number of filter clinics, so the whole thing is set up not as a lone standing hospital, but as a slight network. See what I can flip through here. And we will open this month a new hospital that will provide significantly better care for the government and for the people of Lesotho than the old hospital would have done. So what it brings me back to is I think there's many opportunities short of an entire health insurance system to ensure that people. So this is where we are. So this is the new Lesotho hospital. So there is many opportunities to do to get more out of the money that governments and donors put into the sector today. Let me take another example, and I had the benefit and the blessing of having actually worked extensively in India over the last several years before I've been asked to grow our portfolio in Africa again. India has experimented, not experimented, but they've implemented insurance schemes, as you probably are aware of, basically countrywide today. They have an insurance system that is a social insurance system. People actually don't contribute to the premium. It's for the below poverty line people. It's called RSBY, covers secondary care. And Andhra Pradesh, one of the states that we had an active engagement in, had actually a precursor scheme that was called Arogashi, which I think is also in this little booklet. And I'll recommend that all of you take a few minutes to flip through this booklet. So the government there took a slightly different approach to the insurance question and this hassle of trying to identify groups and sign up groups and convince groups to contribute to the premium. And they said essentially, we're going to do what any employer does. We will actually sign up all our poor people to our insurance package. We will go to the market. We will tender for insurance companies to come in and underwrite those lives. Okay? And we will pay the premium on behalf of these poor people. And we will basically, wait out the time until the trust builds, until the comfort level with the scheme builds, that maybe at some point in the future we can ask people to make a contribution to that. But in recognition that this is not going to get started on day one, they basically took a laissez-faire approach, which was helped by the fact that they had the fiscal space to do that. But the key point is, again, it's a public-private partnership where essentially the government says, I would like this insurance solution. I cannot really manage it myself. So in Africa, we have a number of countries that have tried it, but they're trying to manage much more of the insurance services actually themselves. If you look at Ghana, in part, I think also Nigeria, and basically went to a competitive process to select a private partner to implement this. Now the trick, and I think that your point was very, very important, is that this system doesn't really work if you have nothing on the supply side. So if you ask people, you get the insurance card, but essentially where you live, you go to the same crummy primary healthcare clinic where the doctor doesn't show up. And where our evidence, the World Bank Group's various studies show that people going to the primary healthcare clinics with clear indication of a heart attack essentially get, in almost no case, a correct diagnosis or treatment. Okay, so they get much better treatment and diagnosis when they go to someone who's opened a healthcare shop along the road and used to run a restaurant before, because they sort of make a bigger effort to try to diagnose what you actually have. And so it comes back to the fact that incentives matter in healthcare. So how much level of effort does a doctor spend on a patient? And it has to do with the fact that there's no infrastructure. And so what we engaged actually in Andhra Pradesh in parallel to the insurance transaction was an effort for the government to fix up its government facilities to be able to provide better care. And we did that to a number of transactions that improved the lab services that the medical colleges can provide, the imaging diagnostic service that these hospitals can provide. And I think if you don't do this, if you don't have any intervention on the supply side, and I think the Nigeria example this afternoon will be very interesting. It's going to be very hard to build the trust in the scheme in the first place, and then the second, in an extension of that, ask people to make a contribution and really expand the pool of funding that's available. But I think the PPPs, the public-private partnerships in that space, can be a very effective tool in our view of expanding this. We have been a bit cautious over the last few years in putting this out. Because we wanted to see how these first transactions really work in Lesotho, in India, what the results are there. We are now sufficiently comfortable to say, okay, this is something we really going to take much more aggressively into Africa. and I hope we can all collaborate on this.
Well, Dirk, thank you very much.